Thank you again for all being here. Very excited for our symposium this morning. And I'm going to kind of pass this over to Julia Olson to help us with a land acknowledgement this morning and tell us a little bit more about the DART committee.
We, at Seattle Children's, would like to honor the Duwamish tribe and the land itself by acknowledging that we are on traditional land of the first people of Seattle, the Duwamish people, past and present. The DART committee meets about once a month or sometimes bi-weekly or bi-monthly to go over ways that we can be more equitably diverse in our medical practices. And so it's important to do a land acknowledgement during some of the meetings just to acknowledge that the land that we are on is borrowed.
Julia, thank you so much. I appreciate it. Monique is going to kick us off this morning to tell us a little bit more about what physical literacy actually is.
I'm just going to do a little brief overview of what physical literacy is, because I think sometimes that term can be a little bit confusing and challenging to understand, and we want to be able to explain it to our patients and families as well as people we're talking to. And so I'll do a little brief explanation so that we can jump into our other speakers and have time for all of that. So physical literacy as a concept, as a term, actually was kind of introduced many years ago, like earlier in the 1980s and whatnot. But Margaret Whitehead was really the one who introduced the concept of physical literacy in 1993. And since then, it has had numerous definitions. And that's actually one of the interesting things I'll bring up, is that it seems to be that like each country has adopted the term of physical literacy, and each country has come up with their own definition of what physical literacy means. But I really think like Canada has been the country who really spearheaded most of this, and is one that we think of when we think of kind of starting the movement of physical literacy. And so they actually had a term for physical literacy, then brought people together in Canada because they really wanted to be able to define what the term is. And they came up with a consensus statement in June of 2015. And their definition that was developed by this International Physical Literacy Association is physical literacy is the motivation, confidence, physical competence, knowledge, and understanding to value and take responsibility for engagement in physical activities for life. Which is like a really big mouthful, right? That's a lot of different concepts in one. So they actually did, I will spare you reading the details of each of this, but they actually broke that down so that it's a little bit easier to understand. And their point was that each of those kind of major terms are interconnected, and they are what defines what's important throughout life. And so they have this little schematic of physical literacy is that whole statement, but then within each of those statements, like motivation and confidence, that's like, you know, the enjoyment and the self-assurance of being active, and then physical competence, it's like developing those physical abilities throughout childhood and into adolescence. And then like the knowledge and the understanding and being able to know why and to appreciate movement, and then ultimately engaging in physical activities on a regular basis for life. So, oops, my mouse has stopped. Okay, let's see. There we go. So they also broke that down into core principles, and they had 5 core principles, like how do you actually achieve physical literacy? And they talked about that it's accessible to all and very inclusive, that it represents that each individual has a unique journey through the process of physical literacy, and involves enjoyment in the different types of experiences. It's something that should be valued and nurtured throughout life, and it contributes to the whole person. So then in our country, the Aspen Institute and Project Play has really kind of been the organization that has really kind of spearheaded the movement around physical activity for all. And so in June 2015, the Aspen Institute brought together 15 different members across different sectors that would be involved in physical activity, brought them together to really look at like how do we make physical activity accessible and something that people will all do. and really come up with a definition that they felt made best. Again, the kind of the theme again of every country has a definition. So they went through and kind of really looked at what are the tools to be active for life and how do those translate into other things. So what has been discovered through research is that children with better developed motor skills are more physically active as early as their preschool years, and that motor coordination is a significant predictor of physical activity during grade school years. And then ultimately youth who are physically active are more likely to stay active into adolescence and to adulthood. So there's a schematic of like, if you can run as a younger person, then that provides the opportunity to do all kinds of different things like tag and soccer, basketball, all the different sports that we think of. Balancing obviously contributes to sports that there's a lot of balance that's needed, and then swimming into like our swimming sports. So those fundamentals of activity. And I won't go into much more detail about that because Kyle's going to speak about that a bit more later. But when we really think, then some research and the kind of the schematic came up with some other researchers around the phases of motor development, and that there's these 4 phases and they build upon each other from infancy all the way into childhood and adulthood. And that it's really around that 3rd phase after just like, running out and playing. And like, obviously kids, like they start to crawl, they pick up things, they're coordinating their hand movements, they're throwing balls, just the things that we naturally do as babies and kids and growing up. And then as you get a little bit farther into that, there's some more fundamental movements. And then they start to branch into some of the more detailed movements that people may do. And that brings us into like specialized activities, and then maybe more sports specific activity. So there's a point in there when the genetic influences aren't really more the driving force. It's more around the access to activity, which I think is a key point, right? Because the access to activity and physical activity is not something that every child has the opportunity for in an equal way. And then also it doesn't take into account the motivational factors, and motivation is certainly something that may be influenced by your environment at home or your access to different activities. So the Aspen Institute also came up with their definition of physical literacy. It's a little bit more condensed and maybe easier to say as less of a mouthful. As physical literacy is the ability, confidence, and desire to be physically active for life. And then again, broke down ability. That's that competency and those basic skills, that overall fitness, allowing individuals to really engage in a variety of activities. So those are informal play, and then some intentional movement training. So that may be running, balancing, hopping, jumping, things that you can imagine you may do in PE. And then things also that may have some little bit of guidance that comes from, for example, like a PE teacher or maybe classes they're taking. And then confidence. So knowing your ability to play sports and enjoy physical activities. And I think probably all of us have experienced friends or our patients who say, oh, I'm not really like much of a sportsy person. I'm more of like a arts person or an academic person. And, where does that come from? Where does that develop, that people are not feeling confident in their physical activity? And how do we create opportunities where everybody feels included and can develop and can grow their skills? And doesn't necessarily have to be an athlete, but they are confident in their body to be able to move it throughout life. And then desire. So that may be just intrinsic for some people, but it also may be something that if young people have a positive experience, that may provide motivation for them to be active. And that may be where sometimes things branch, right? We know kids just want to have fun when they're doing activities. And when the fun goes away, how may that be impacting their interest in being physically active, and start to branch our kids into the athlete and the non-athlete, and how do we move away from that? So Aspen Institute came up with this concept of play, which is physical literacy in all youth. And how do we create conditions for all youth to be physically active and encourage those healthy habits? And we know that actually you need to be able to get kids active before 12. Otherwise, it does, again, you start to have the kids who are more of the studious type or whatever, how do we go away from that concept? This is just a schematic from another organization. So Active for Life, if you're looking for some really kind of nice pictures and things that you may be able to post, or also they have some information online about ways to be active, especially for some of the younger kids, then this is a nice little thing that you can just download and make a poster of online. But part of their point was that early physical activity leads to like more like happiness, better academic achievement. If you really think about how academics, physical activity helps with wellness and your mood, and also for some kids getting their wiggles out so they can be more focused. Obviously, it has a really important health component where we reduce our costs from a medical care perspective, and then it seems that apparently people have higher earnings, which I think probably is related to really thinking about, what does exercise and activity do for you? And maybe that helps an opportunity to reach different potentials. So how do we actually help and contribute? And the Aspen Institute really decided to bring this movement into how do we as a country and community really engage in the physical literacy concept. And so they gave recommendations of a cross-sector collaboration, and we will be able to hear about how that was really seen in our community through what's now the King County Play Equity Coalition, and looking at the state of play in King County, which Julie McCleary will be talking about a little bit later. And also bringing in like leaders, tools, resources. How do you measure physical literacy and really be more of a global collaboration, since this is something obviously that impacts everyone in the world? And like I said before, there's a lot of like different movements throughout various countries, and how do we all work together on these concepts? So what's our call to action? I think as healthcare providers, how do we just start to ask that question? I mean, most of us here are involved in sports medicine, right? So many of our patients aren't necessarily people that we have to motivate to be active. Sometimes we actually have to have conversations about how they need to pull back, and so that allows them to be active for life. But I think we can see that play out, certainly people who are in the clinical setting at the hospital, of maybe just asking. And so asking your patients, like, what are they doing for physical activity? How many days a week? How many minutes are they doing that activity? So the concept of physical activity as a vital sign. And then trying to figure out what are their barriers? How do we also help the patient and family move away from their concept of they just aren't a very active person, that's not their personality, and how do we encourage them to engage in activity and play because of all the benefits that it brings? Then the prescription for physical literacy, which we also know is like the exercise prescription. Exercise is medicine. We're calling it the movement plan in my movement clinic, which I'll briefly talk about at the end. And we have our athletic trainers who are going to talk about how they're contributing to movement and exercise prescriptions within our various specialty clinics at the hospital. And then also being an advocate. So when there's opportunities within our community or our legislation to be an advocate for the importance of physical activity, whether that may be advocating for physical activity in the schools or access in our communities that will bring more people to be active, I think is really important. And at the end, we're going to hear from Stacy, and just thinking about like the disparities around access in our youth sports. And like I said before, Julie's going to talk about really within our own community, where are we experiencing disparities in access to physical activity, and how do we break those boundaries for our patients and families so that everybody has the access to be physically active. So when we're encouraging them, we're able to really think through how everyone can have those opportunities. So that is all. And we have some really great presentations that are going to address the various aspects that I think this call to action has for us. So I'm going to turn it over. Well, I'll turn it back to you, Tara, and we're going to have a really wonderful presentation from our athletic trainers who are in the high school, but they also are doing some fun things right here in our own clinic. So
I would like to just give a couple short bios for our next three presenters. Grace Catt graduated from Central Michigan University's athletic training program in 2018 and began working for Seattle Children's in August of 2018. Since joining the athletic training program at Children's, Grace has provided healthcare coverage for athletes at the Bush School and has been a fitness specialist for the Child Wellness and Cystic Fibrosis clinics. Julia Olson attended Wisconsin Eau Claire, where she obtained her BS in athletic training. She also attended the University of Minnesota, where she obtained her Master's in Education in Sport and Exercises Science and sat for her CSCS exam. She's worked in a variety of settings, including collegiate and industrial, and now works as the head athletic trainer at Holy Names Academy. Carlos Orlina has been a certified athletic trainer since 2014. He graduated from the University of North Florida and practiced there for 5 years. He then moved to the Evergreen State. He has been practicing athletic training in Washington since the summer of 2019. Carlos is the athletic trainer at Rainier Beach High School and the fitness specialist for the Type 2 Diabetes Clinic. Thank you for being here and presenting, and the floor is yours.
Thank you so much, Tara, for that introduction. Again, my name is Julia Olson. I'll be one of the presenters today.
I'm Grace. I'm another presenter, and as Tara said, I'm at the Bush School, and I also work at the Child Wellness Clinic and spent some time in the Cystic Fibrosis Clinic.
Oh, hey, I'm Carlos Orlina. I'm the athletic trainer at Rainier Beach High School, and I am the athletic trainer for the Type 2 Diabetes Clinic.
So we just want to disclose that the three of us do not have any actual or potential conflict of interest in relation to the presentation that we're about to present. Today, our objectives are to identify which specialty clinics athletic trainers work in, understand the typical fitness visit and what that all entails, review the 60-minute recommendation by the World Health Organization, and then identify barriers to increasing physical activity and provide solutions to those barriers.
Yeah, so we're just going to do a brief overview of all the specialty clinics our athletic trainers are in. We could spend so much time talking about each of these clinics and what our athletic trainers are doing in them. But like I said, just a quick overview, but we've also included the contact information for the athletic trainers in these clinics, so you can reach out if you want more information. So the Cystic Fibrosis Clinic works with patients under the age of 21 who are diagnosed with cystic fibrosis. The care team includes an MD or a nurse practitioner, nurses, athletic trainers, registered dietitians, genetic counselors, respiratory therapists, and social workers. This clinic is unique because it's the only specialty clinic that we cover where most of the patients are actually underweight. Here, the patients can choose to take part in the exercise program, which would include a fitness assessment every 6 months and check-ins every 3 months. And we have Mike and Bethany in this clinic. And then we also have the Child Wellness Clinic, which works with patients between the age of 2 and 12 with a BMI greater than the 95th percentile. And this is with or without associated health conditions or concerns. There are 2 clinics. There's one in the main campus, Seattle, where I'm at, and then there's one up at the North Clinic in Everett, where Ryan is at. The care team includes an MD or ARNP, a registered dietitian, athletic trainer, and social workers. And here we're going to meet with patients 5 years or older. We don't really meet with the younger patients because it's really just active play, and that tends to be more of a nutritional or medical issue if they're overweight at that age. And then we will determine how often they need to see us based on our fitness assessment. So some patients will see every 2 to 4 weeks, or others will see once a season.
We also work in the fatty liver program. So in this program, we're seeing patients under the age of 21 who are diagnosed with non-alcoholic fatty liver disease. This care team consists of a pediatric hepatologist, athletic trainers, registered dietitians, and psychologists. And Taylor Spicer works in that clinic. Taylor and I also work together in the insulin resistance clinic. So we're seeing patients under the age of 21 who have an A1C between 5.7 and 6.4. Basically what A1C is measuring is their blood glucose levels, and the children that we work with are considered at risk for type 2 diabetes. So in this clinic, we try to mitigate the risks of them developing type 2 diabetes. Our care team consists of doctors, nurse practitioners, athletic trainers, registered dietitians, and social workers. And in this clinic, we work alongside them and provide exercises and things like that, but a little bit different than child wellness in that we only have a medical exam room. So some differences in the clinics and the spaces that we use.
Tagging along with the insulin resistant clinic is the type 2 diabetes clinic. Um, Once those A1C levels are a little bit too high, over 6.5%, then they come over to the type 2 diabetes clinic. The care team includes the MD, the registered dietitian, me as the athletic trainer, and social workers. In this clinic, it's about the same as the IR clinic, where we try and help the kiddo lower down their A1C levels through diet and exercise. Social workers are usually there to help out as well, just to help out with family stuff that's going on.
So I'm going to discuss what a typical fitness visit looks like in our clinics. These are going to vary depending on the clinic specialty and patient specifics. I also want to point out that I'm going to be using the term obesity a lot in this presentation. When actually working with the patients, we use terms like body or larger bodies instead of fat or obese. Similarly, when discussing fitness or physical activity, we tend to say moving your body or movement. Sometimes exercise or fitness can be a triggering word for our patients. Language is extremely important when working with these kiddos because a lot of them have already been bullied due to their weight. So the objectives for the fitness visit are to identify any contraindications or red flags, identify the cause of obesity, which this is a really complex process. It's going to involve multiple visits and providers. We also want to examine for neuromuscular impairment and assess cardiovascular fitness. This is going to be through subjective information and the movement assessment, but the movement assessment isn't always indicated based on patient comfortability and willingness. And then we're also going to facilitate buy-in and understanding of why movement is an important part of a healthy lifestyle and utilize SMART goal setting. So Julia's going to go over this in more detail later, but these are some considerations we want to have throughout our visit. So we want to consider developmental, socioeconomic, and cultural contexts, the child's preferences, the social support that's available, their body image and comfort with movement, and self-efficacy and confidence. These are our contraindications or red flags. Often these are already noted during their initial visit with the medical provider who they will meet with before they meet with us, but it's just good to be aware of in case anything comes up during our visit. And then on to identifying the cause of obesity. So obesity is a really complex condition that results from many interconnected factors. So we work with the other providers in our clinic to determine a potential cause. Sometimes I'll see a patient who's super active, has great biomechanics, and is going above and beyond the daily recommendations for physical activity. And so that might indicate that their weight gain is from a different cause, such as an unhealthy diet, and they would meet with the registered dietitian more often. This chart is showing it from a movement perspective. So this is what's going on in my head throughout the assessment. For example, one patient I see has pes planus, and when they walk for long periods of time, they have foot and back pain. So this is limiting the functional movement of walking, and then they aren't able to be as active with their peers because of this pain. Another patient of mine has poor body image and self-esteem, so they don't feel comfortable being physically active in front of others. And so this reduced participation has led to some muscle weakness in their core and lower legs. And so now as they try to exercise more, they have some discomfort in their knees. So it's really complex, and all of these factors are kind of playing off of each other. It's also important to note that there's secondary causes for obesity. The list off to the side is nowhere near exhaustive, but what I typically see in my clinic are hypothyroidism and psychological issues resulting from trauma. Another way to kind of identify the cause of obesity is through a thorough review of their weekly routine. So I spend a lot of time in my assessments just kind of chatting with them and seeing what their typical schedule is like. So we go over the school day, if they have recess or a PE class, and if they're actually participating fully in those, and then what they do after school to bedtime. So if they have any organized activities, do they have chores? Do they have siblings they play with? And then also looking at what they're doing on the weekend, because I do find that a lot of our patients will just sit and watch TV or play video games all weekend. And then some additional considerations are caregiver supervision, if they have a safe area to play, what screen time is looking like, especially with this younger generation and the pandemic, and then also looking at how much sleep they're getting. So once we have some idea of a potential cause of obesity, we can examine for neuromuscular impairments. These neuromuscular health questions are either asked directly or we observe them during the movement assessment. For the sake of time, I'm not going to read through all of these, but these are kind of my, if I only have 5 minutes with a patient and I want to understand their relationship with movement and how it could be playing a role in their weight, this is what I would ask. So of course, we want to ask if they're in pain and if movement is painful, because we don't want them doing anything that's harming their bodies. Fatiguing quicker than peers is one of the most common concerns I discuss with the caregivers. So this could be due to perceived exertion, greater muscle fatigue, or impaired respiratory function. This is also a good time to bring up sleep if we haven't discussed that yet, because it could indicate a need for sleep screening. And then we also want to ask about balance and falls because we want to make sure they feel comfortable moving their body and are able to do in a safe way. So this next question, we are diving in a little deeper about their relationship with exercise and their peers or the community. A lot of times children with obesity can have impaired fundamental movements, and this might make them uncomfortable moving in front of their peers. So a lot of times I'll recommend practicing the activities at home. So if they want to join a soccer team but aren't comfortable joining the team quite yet, we'll discuss maybe passing the ball back and forth with the parent at home. And as they get more comfortable, they can join the team later on. This is also a good time to bring up social isolation, teasing, and bullying, which could indicate a need for a follow-up with social work. And then we also want to ask just how much activity they're getting in an average day, because that means, or if they're not getting the daily recommended amount, that means they should probably continue following up with us. And then lastly, we want to ask what goals they have, just so we can see what the parent and family wants to get out of these visits, and what goals might motivate them. Okay, so here are some common neuromuscular impairments that we might see. So increased pain, especially in the spine and lower limb. We also might see reduced lower limb strength, impaired coordination, gait deviation, and postural malalignment. What we see most in the literature is genu valgum and pes planus with children with obesity, but a lot of times I'm also noticing forward head posture and rounded shoulders. And then we're also might see reduced motor skill proficiency. So while ideally we're doing the movement assessment at our first visit, it's not always appropriate based on the patient willingness and comfortability. A lot of times they're, out of all of our providers, they're the most nervous to see me, the fitness specialist. And this is just from negative past experiences with maybe coaches, PE teachers, or even healthcare providers. And sometimes it causes them to shut down. So it's more important for us to build trust and rapport than to pressure the patient into movement. So sometimes I'll show them this list of activities we can do and have them pick out what ones they're comfortable doing. And then next time I meet with them, maybe we can work up towards the harder exercises. And then I also want to point out that perceptions of lower health and fitness can impact the outcomes of our assessment. So I spend a lot of time showing them alternative ways to do these exercises, or encouraging them and cheering them on to hopefully build their confidence. And so as you can see, this movement assessment is pretty basic. We're looking at their posture and gait, looking at coordination, typically with skipping and marching, cardiorespiratory fitness by doing jumping jacks, or in the Cystic Fibrosis Clinic, we utilize the Bruce protocol for VO2 max. Also looking at their balance with single leg balance and tandem gait, strengths with push-ups, squats, and sit-ups, and flexibility, just kind of bending and seeing if they can touch their toes. And then if I have time, sometimes I'll just kind of play with them or use what we have in the gym to test their motor skill proficiency. And then kind of our last two objectives are to facilitate buy-in and understanding. So we want to educate them on the benefits of exercise, explain how exercise can help enhance the activities that they're already passionate about and want to do, and then also make sure that we're meeting the child and family where they're at and listen to their concerns. And then we're going to utilize SMART goal setting to create some activity goals. So these need to be specific, measurable, action-oriented, realistic, and time-limited. Julia's going to go over that a little more later, but in general, we want to work them up towards 60 minutes of physical activity a day, which is the general recommendation that Carlos will go over now.
Okay, so the daily recommendation of physical activity, we're going to discuss the amount of time dedicated to physical activity, child and adolescent. So according to the 2020 World Health Organization guidelines, they recommend about 60 minutes of moderate to vigorous intensity of physical activity for health benefits. So what does it mean to be moderate to vigorous? According to the CDC, they state that on a scale of 0 to 10, 0 meaning that you're sitting and 10 meaning you're profusely working out, they want you to be around 5 or 6 on that scale. The World Health Organization guideline also recommends that at least 3 of those days during the week should involve some kind of activities for strengthening the muscles and the bones. Some of the health benefits that are included within these 60 minutes of physical activity include an improvement in your physical fitness, overall improvements in your cardio and your muscular strength, an improvement in your cardiometabolic health, meaning your blood pressure is going to be good numbers. Dyslipidemia is an abnormal amount of lipids. Getting physically active, you're going to be decreasing your triglycerides, your cholesterols, and those fat phospholipids. Also, improvements in your glucose and your insulin resistance. Obviously, as we all know, physical activity is going to improve our bone health. As Dr. Burton said earlier, physical activity does help out with cognitive outcomes, better performance in academics, and better executive thinking. Executive thinking falls under working memory, time management, organization, and self-control. Overall improvement in mental health. There's a reduction in depression linking to physical activity, and a reduction in adipose tissue, which is your body composition. These are some of the workouts that I enjoy prescribing to the kiddos whenever they come in. Using the movement assessment, we like to see what it is that the kiddos enjoy to do. Like Grace stated, we try and see what their daily habits are. What do they do after school? What activities are they involved in? And what do they involve in themselves in over the weekend? Nowadays, most of the kiddos are kind of either on a phone or an iPad playing video games or watching Netflix on TV. So we kind of challenge them to kind of get up and get going so that they can reach that 60 minutes of physical activity a day. One of my favorite activities is the activity here that says spell your name and do the workout. But I sometimes challenge the kiddos to not only spell their name, but spell different objects, spell different words. For example, I know one parent enjoyed this. I had a kiddo, I challenged him to spell out words or spell out foods that he enjoyed. So if he was eyeing the cake in the fridge, he had to spell out cake, which is 20 squats, 20 arm circles, 30 arm circles into 20 push-ups, and his reward be small piece of cake. Another one I like to enjoy to give out is the after school workout. As Julia will explain, sometimes some barriers are not being able to go outside, so they'll be stuck inside. And so this is a quick workout that they can do when they are inside, and among other things. Obviously, we can't always be physically active. These kiddos would always want to kind of relax after a long day at school. So the World Health Organization guideline states that no more of 20 hours of recreational screen time. They do recommend that these 2 hours be broken up by either getting up and moving around, walking around the house. Sometimes or at least I like to let the kiddos know, hey, maybe during commercial breaks, you get up, do some push-ups or air squats. I mean, virtually now, Netflix shows or any of the sorts, they don't really have commercial breaks. So I challenge the kiddos to kind of put a timer, probably every 5 minutes, get up, walk around the house. or do some push-ups while there's a boring part of the show going on. And like Grace said, a lot of screen time has been going on since pandemic had happened. But we kind of challenge these kiddos to look up videos on YouTube for exercise. I know I had one kiddo do a dance thing on YouTube where there would be music playing, and then they had different dance moves that they had to perform to the different music.
Okay, I'm going to finish us off here with some barriers to physical activity. Our objectives during this time are going to be to outline barriers found in our clinics and then offer some solutions to the barriers and steps moving forward. One of the largest barriers that we as healthcare professionals deal with is socioeconomic status. So there's a link to higher rates of obesity in lower socioeconomic status individuals. And this could be due to a variety of things, but a couple of them being lower quality food and therefore increasing their consumption of fat and simple carbohydrates, or simply just eating less fruits and vegetables or whole wheat bread. Another reason that socioeconomic status can impact activity levels is the safety of their neighborhood. So if their neighborhoods aren't as safe, then they may have less access to gyms, playgrounds, and other safe areas for movement, um, really confining them maybe to the household, or they don't have a backyard to play in. And then another thing is that we require lifestyle changes for the entire family in order for our patients to adhere towards their goals. And some of these families may be stressed out by medical bills. And we can't discount the amount of work that families need to do to adhere to the biomedical markers and A1C levels that we're looking to reduce. And if we have families that are working as a single parent or multiple children in the house that maybe can't have require the same attention for the patient, then we're going to see some discrepancies there. In our clinics, we also deal with a lot of population or work with a lot of populations, sorry, that have language barriers. So a lot of the resources that we have in our clinics are in English. And standard verbiage for exercises that we prescribe are all English leaning names. So because of this, some things might come off confusing. In addition to that, we put in wrap-up notes that can be visible in my chart to the patients, and those wrap-up notes are written in English. Some of the tools that and programs that we use, such as YouTube or Go Noodle or Peloton, are apps that are mostly in English or provide only a Spanish alternative. And accessible fitness routines may not be provided in their specific language. In addition to that, we have patients who are working to really try and increase their understanding of English. And so they might deny interpretation for their visit, or the child might be fluent in English and kind of mainline the entire conversation, leaving out the parent not knowing exactly what's going on. So those types of barriers can influence the adherence to the family leaning goals that we're setting. In addition to that, body image and comfort with movement. So again, our movement assessment is always optional. We're going to gauge how interested the child is and gauge their comfort level in our movement assessment. We also, again, try to shy away from things like fitness, obesity, and fat during our visits. Some patients also don't see an increase in self-efficacy from movement. So some of them have fear of moving in spaces where others can see them. And some of them have safety concerns about moving, or it just doesn't feel good on their body. And lastly, here we're going over safety. So again, this ties back to socioeconomic status and supervision of exercises. Also, we work with a younger population, and due to this, a lot of their movement needs to be guided with a parent. If the parents have long working hours or aren't changing their own behaviors and holding their children accountable, it's almost impossible for children to meet their goals. And age and autonomy really play into this as well. So we might see a better adherence or more autonomy with our higher age population than we will with our younger age population, because they rely heavily on their parents to meet their goals. Okay, and then finding solutions. So this is the last part that we're going to go over. Again, we're making SMART goals. So we want to make sure that we're tailoring our goals specific to their socioeconomic status needs, their language needs, and then just their body awareness and autonomy of their movement, and be creative in what we think of as exercise. So for example, if we have a really artsy kid who enjoys acting or dancing, then a school musical where there's dancing and movement there might be a good option for them for physical activity. And then we also want to determine what may be appropriate to track their movement, whether that be time or rate of perceived exertion. In the insulin resistant and diabetes clinic, we actually can give out Fitbits as rewards for children meeting their goals, and get to know the patient for what motivates them. So if the Fitbit might be a motivating factor for them, then use that as a tool to help them. And then we also want to make sure that we're willing to provide a safe space for failure and to redo goals and increase adherence. So we take the any movement is better than no movement approach. Yes, we want them to be getting 2 hours of movement a day, but if the child is currently doing 0 and we can get them to do 5 minutes a day, then that's going to be a small and specific attainable goal that we're going to get them to do, and congratulate them when they accomplish that. If they aren't successful in that goal, then we need to reassess our plan, determine the barriers that they're facing, and then make a new plan for them so that they can be successful the next time. So here are some of the references that we used in our presentation today. And I know we're getting a little short on time, so Tara, I'm going to bring it back to you.
Thank you. I appreciate it.